We are live.
Good evening, everyone. Welcome to iFocus Online, lecture number 534 of Optics and Refractive module. So today we'll be discussing about astigmatic lenses, Maddox rod and Jackson cross cylinder, and the lecture will be taken up by Dr. Lakshmi Kuniyal, ma'am. The moderator for today's class is Dr. Deepa Gupta, ma'am. She is a senior cataract cornea refractive surgeon. She's the HOD and co-partner of the LAL 2020 Eye Care Center and LAL LASIK Center in Gurugram. She has performed over 20,000 cataract surgeries and over 1,000 corneal transplants. She's an expert in LASIK, SMILE, ICL, and various other ocular surface surgeries. She has a special interest in keratoconus management and premium IOLs as well. She has been actively involved in teaching, presentations, and live surgeries at various conferences in India. She has served as a moderator, a panelist, and judge in academic sessions for more than 10 years. Ma'am has performed various live surgeries, and also she is the winner of the OPL Trophy at AIOS Kolkata in 2024. We welcome you, ma'am. The chairperson for today's class is Dr. Rupal Shah, ma'am. Ma'am is fondly described as the mother of smile. She is the first person in the world to do one incision smile surgery and the first in the world to use circle software in a patient for retreatment in smile. Ma'am has trained more than 2,000 ophthalmologists from across the world and has conducted various intensive LASIK training courses for many ophthalmologists in India and worldwide. She has many national and international publications and presentations, and also she is the recipient of numerous awards and gold medals. We welcome you, ma'am. The speaker for today's class is Dr. Lakshmi Kuniyal, ma'am. She is currently the director and senior consultant at Aarogyam Health Clinic, Mathura. Ma'am has held various positions at various eye institutes, which includes Center for Sight, Safdarjung, ex-consultant at IQ Gurugram. She was also the HOD of the Nayati Medicity at Mathura and various other eye centers in Mathura. She's a member of AIOS, DOS, and VRSI. She has multiple papers published in multiple international journals, and also she has worked as a clinical paper reviewer. She's actively involved in webinars on various clinical platforms. We welcome you, ma'am. Over to you, ma'am.
Thank you so much, Dr. Servin, for this kind introduction. And I'll be sharing my slides now. Are they visible?
Not yet, ma'am. They are visible, ma'am.
Yeah, I'll just make it a full slide presentation. Yeah. So thank you so much once again, Dr. Savin, for this kind introduction. And I also thankful to the iFocus for giving this opportunity. So the today's topic for the iFocus online, as mentioned, is the optics and refraction module. And I have to speak on Geometric Optics Part 4, which will include the astigmatic lenses, Maddox rod, and the Jackson cross cylinder. So let's first see what we actually mean by astigmatic lens. As we all know, astigmatism is an imperfection in the curvature of the eye's cornea, that is the front surface, or the lens inside the eye. Normally, the cornea and lens have a perfectly rounded curvature, just like a basketball, which refracts light evenly onto a single point on the retina for a sharp image. But in cases of astigmatism, the cornea or the lens is misshaped, often more like an oval or a football shaped, which will cause the light rays to bend differently and create multiple focal points on the retina instead of one. And this would result in blurry or distorted vision at all distances. Now, how do astigmatic lenses work? Now, astigmatic lenses we can find in the form of eyeglass or contact lens or toric intraocular lenses. They work by compensating for the irregular curvature of the eye's cornea or the lens. They refract light unevenly in a way that counteracts the eye's uneven focusing, bringing all the light rays to a single focal point on the retina. This would help to correct the blood vision and would help to provide a clear, sharper image. So you can see in the corresponding image, when we put a astigmatic lens, it helps to focus the different rays to a single point, thus making the image clearer and better. Spherical lenses, they help to correct hyperopia, myopia, and presbyopia, whereas the refractive errors that spherical lenses cannot correct, they are the astigmatic ones. So what we intend to learn from the upcoming slides, we'll learn to list the type of refractive errors that astigmatic lenses can correct. We'll explain the difference between a cylindrical lens and a spherocylindrical lens. We'll see the principal meridians of a spherical cylinder, of a cylindrical lens. We'll see the shapes of astigmatic lenses and explain how these astigmatic lenses they focus the light and how to interpret and write the power of a spherocylindrical lens. Astigmatic lenses, they are used to correct the focus of the eye of the people with astigmatism. Astigmatic spectacles can correct the focus of people who have astigmatism combined with another refractive error, which could be in the form of astigmatism with hyperopia, astigmatism with myopia, and astigmatism along with presbyopia. When we talk about astigmatic lenses, they are of primarily two types. They can either be pure cylindrical lenses or it can be a combination of spherocylindrical lenses. A spherocylindrical lens is nothing but a cylindrical lens combined with a spherical lens. Now, meridian is one of the important aspects of a astigmatic lens. So what is it? It's an imaginary line which crosses a lens at its optical center. Now here we see the examples of two. One is the spherical lens here and the second one is the cylindrical. Now astigmatic lenses, they have different powers in different meridian. Whereas the spherical lenses, they have same power in all the meridians. So you can see in the first picture that the power would remain same in all the meridians. But in case of astigmatic lens, the power would differ in these two different meridians, which are perpendicular to each other. Now let's talk about the cylindrical lenses. Now they can either be a minus cylinder or it can be a plus cylinder. Now we just talked about the two principal meridians. We said one meridian is the axis meridian, the other being the power meridian. Now why do we call it as a power meridian? Because it has the maximum power, whereas the axis meridian will have either the minimum or the zero power. Now, to understand this, we have to go to the cut section of these lenses. So when we cut a spherical lens, what do we get? So when we cut along any meridian in any direction of a plus spherical lens, we always get a one flat edge, the plano, or other would be a convex edge. So if we cut a lens through the optical center of a spherical lens in any direction or in any meridian, the shape of the two cut surfaces will always remain the same. And this is why a plus spherical lens will have the same power in all the meridians. Now, when we cut a cylindrical lens along the power meridian, we have just taken the example of a plus cylindrical lens. So we are getting one surface, which is the plano, and other is having a curvature, that is the power. So when we cut any cylindrical lens along the power meridian, we'll get two halves, as has been shown in the picture. The cut surfaces, they are the same shape as those of the plus spherical lenses. One will be a flat and other will be a convex edge. That means this will be the area which will give you the power. So one of the meridians will be having a power, that is the one of the meridians. But if we cut it along, this is written wrongly, it has to be this can be power, this will be along the axis meridian. So when we cut the lens along the axis meridian, we get these two pieces where these two lines, they are parallel to each other. So if we're cutting a cylindrical lens along the axis meridian, we're getting two surfaces that have two flat or plano edges, which are straight and parallel. That means the axis meridian has got no focusing power. So let's see how the refraction is happening through these cylindrical lenses. So we have one plus spherical lens and we have taken one cylindrical lens. So in case of a spherical lens, the incident rays, when they fall off the lens, they converge to a focal point. But in case of a cylindrical lens, when the incident rays they are following, they're not focusing on a single point, but they are following a focal line. So the spherical lens is refracting the incident rays to a focal point, but a plus cylindrical lens will refract light to a focal line rather than a single focal point. And this is what we see in this picture here. Now, what happens when the refraction is happening through minus lenses? The same concept goes as it goes in the plus, but the image would be formed virtual. So we have to trace back the incident rays backwards. And in case of a minus spherical lenses, there will be a virtual focal point behind the lens. Similarly, in case of a minus cylindrical lenses, when you trace back the incident rays backward, it will form a virtual focal line. Now, when we talk about refraction through spherocylindrical lens, we've already mentioned that's a combination of either two cylindrical lenses or a combination of a spherical with a cylindrical lenses. So you will, that's why we also call it just spherolenses lenses or spherocylindrical lenses. Now you will have two different meridians, vertical meridian here and horizontal meridians. So here the one of the plane will be focusing at one point, the other vertical meridian will be focusing at the other point. So we'll have two different points of focus, and we'll just see that why the spherical cylinder, when it is focusing different points, it gives us the Sturm's conide and the circle of least confusion. So which why it is important, we'll see in the upcoming slides. Now, when you talk about the spherocylindrical lenses, now it depends upon that which curvature is carrying how much of power. Like suppose we take the first example. So here we have the +8 more on the more convex structure, while the less curvature side is having less power. So effectively, we say it becomes a +4 diopter lenses. Similarly, when you go for a concave lens, we say that more concave area has got a -8 power and less concave has got comparatively less power. So the effective becomes -4 diopter lenses. So spherocylindrical lenses, as we said, we also call them as spherocylindrical lenses because the two cylindrical lenses, they have been stuck together perpendicular at 90 degrees, or a spherical lens has been stuck to a cylindrical lens, giving you the effective power. The spherocylindrical lenses, they have power in both the principal meridians, but a different power in each. Power meridian, as we said, has a maximum focusing power, while axis meridian has a minimum focusing power. The difference between a pure cylindrical lens and a spherocylindrical lens is that the power meridian in both the condition will have the maximum focusing power, but the axis meridian in case of pure cylindrical lenses would be 0, but here it will be in case of spherocylindrical lenses, it will have some value to it. It won't be 0. So again, I think it shows the same thing that unlike cylindrical lenses, the axis meridian of a spherocylindrical lens has a power that is greater than 0, and plus spherocylindrical lenses forms two focal lines, and a minus spherocylindrical lines, they form two virtual focal lines, and not just like we see in case of a cylindrical lenses. When we talk about the axis rotation in these lenses, it is important for us to note that both for right and left eyes, we measure it anti-clockwise from the horizontal meridians in degrees. So it always has to be anti-clockwise. Now, how do we write a spherocylindrical lens power? So it is written in terms of DC is a short form for the diopter cylinders. Now, this is the example which shows you -4 diopters, and it is in the denominator, it is -1 diopter cylinder at 90 degrees. So the upper one, that is numerator, shows you the spherical power. The denominator shows you the cylindrical power along with the axis. So in simplification, we can write it either in -4 diopters / -1 diopter cylinders 90 degrees. So this is, we're supposed to write the power of an astigmatic lens. Now let's move on to the second topic, that is the Jackson cross cylinder. Jackson cross cylinder is also known as the cross cylinder or the flip cross technique. That's a fundamental tool which is used in optometry or ophthalmology for accurately measuring and refining the axis and power of astigmatism during eye examinations. Now, this is the picture of a JCC. Now, what JCC is, it is essentially two cylindrical lenses of equal power, but opposite signs, like it is plus minus 0.25, or it can be a 0.5, which is the commonest one which we use. Now, they are oriented perpendicular to each other. Like we can see the example here, they are aligned perpendicular to each other. And they're mounted on a handle which is positioned 45 degrees to the axis of the cylinder. So this is how the JCC is formed. Now, what is the purpose of JCC? Why we're using JCC? So it primarily serves to detect the presence and degree of astigmatism. It refines the axis of the astigmatic correction, and it determines the precise power of the astigmatic correction. So it basically allows for precise and accurate correction of astigmatism, leading to the best possible vision for the patient. Now let's see what is the principle behind JCC. When we talk about any optical system, like in our presentation, that is an eye is our optical system. So the two principal meridians, because of the different curvatures of the cornea, the two principal meridians will be focusing at different points. So it will be focusing at two focal points, and in between these two focal points, we'll have the interval or conoid of Strum. In somewhere in between, you will have a point where there'll be equal point of convergence from one meridian and equal point of divergence from another meridian, and that will be the area which will give you the least blurred image, and that is why we call it the circle of least confusion. Now, how the Jackson cross cylinder works. So the first step in Jackson cross cylinder is that we use a spherical lens to place the circle of least confusion on the retina. In step 2, we align the Jackson cross cylinder in front of the patient eye. Either it's going to increase the interval of Strum or it's going to decrease it. Now, when the interval of Strum would increase, the circle of least confusion become larger and the patient would report blur. So we have to look for the position where patient sees less blurred image. That means the circle of least confusion has to become smaller. In step 3, we'll place a cylindrical power according to which side patient was choosing in step 2. That means we want to have a smaller size of the circle of least confusion. But when you place the astigmatic lens in front of the patient eye, it will move the circle of least confusion away from the retina. And for the same reason, we have to add the opposite power, half of cylindrical power, to the spherical power. Now, before we start with JCC, it is important for us to get the refraction either from the retinoscopy or from autograph or for the previous refraction. If nothing is available with us, we can use either fogging or defogging or the subjective refraction. So we need to have initially need to have a refraction before begin with JCC. So first, take out the best sphere which gives the maximum visual acuity. So how the procedure stands. So first we adjust the spherical power. We see whether the cylinder is present or not. If it is not there, then we have to see whether the cylinder is missing or not. So you have to discover the cylinder. If cylinder is present in your in the refraction which you have done, then you have to refine the axis first, and then you go for the refinement of power. So first step, we are working on detecting astigmatism. Initially, the JCC is placed with its axis at 90 and 180 degrees, and then we place it at 45 and 135 degree. Now, if the patient reports no difference in vision, then significant astigmatism is unlikely. Let's see one other example where we have placed Jackson cross cylinder, so the axis is towards 90 or 180. If the patient says position 2, where the axis of the minus cylinder was pointing towards 180 degree, is clearer to the patient, we have to make note of this axis. Then we will place the Jackson cross cylinder obliquely so that the axis is towards 45 and 135 degree. Now, in this condition, if again patient says position 2, where the axis of minus cylinder was pointing towards 135 is clearer, then again we have to make a note of this axis. So now the cylindrical power would be somewhere in between these two. So now you have to place a cylindrical power on the trial frame in such a way that it lies somewhere in between 180 and 135. So it approximately goes around 165. So that was the way how we're discovering the astigmatism. Now, we have already taken out the refraction through retinoscopy. Now, we want to refine the axis. So that is the second purpose of using the JCC. When we do the refinement of the axis, it's important that the JCC handle is aligned with the presumed axis of astigmatism. So handle has to be aligned with the presumed axis. Now, JCC will be flipped and the patient will indicate which view is clearer. The cylindrical axis in the trial frame is then adjusted towards the direction preferred by the patient. So usually we see towards the minus cylindrical axis for minus cylinder notation until no difference is perceived. Like in this example, the retinoscopic value is -1 and -1 decel at 180 degrees. Patient says in the position 1, that means when we have placed, we have aligned the handle of the JCC with the presumed axis, that is 180 degree, and patient sees in position 1 that he sees clear. So we are supposed to rotate our axis towards that side. So the minus correcting cylinder lenses will be rotated towards the direction of the minus cylindrical component, that is the red of the cross cylinder. And if patient says the other side way, then you have to rotate to the other side, is the plus correcting cylinder. Now question comes that how much we are supposed to rotate. So the Del Prior and Guyton has given the guidelines for the initial change in the correcting axis position relative to the power of the correcting cylinder while checking the axis. So in patients where the power of the correcting cylinder is less than 0.25 dc, then you have to rotate around 30 degrees. If it is around 0.5, 15 degrees, that means as the power of the correcting cylinder is more, you have to rotate it less. It makes sense also if the power is more, even a slight adjustment will basically patient can make out the slight adjustment if the power of the correcting cylinder is more. The third step comes is the refining of the power. So once the axis is determined, the JCC's axis is aligned parallel to the astigmatic axis. So here the difference lies. There we were just aligning parallel to the handle. Now it is aligned parallel to the astigmatic axis, which we have just found out. Now the JCC is again flipped and the patient would indicate the clearer view. The cylinder power in the trial frame is then adjusted either to increase or decrease by small increments based on the patient's preference. An important point to remember is that for every 0.5 dioptric change in the cylinder, it's important that we have to add 0.25 to the sphere to maintain the circle of least confusion in the retina. That means the spherical equivalent has to be maintained. Let's see an example here. Again, it's a retinoscopic value of -1 and -0.5 decel at 120 degrees. We have used JCC of 0.5. Patient prefers the lens when red markings are aligned with the cylindrical axis of the trial frame. So you have to add -5 to it. Now, patient prefers the lens when white markings are aligned with the cylindrical axis of the trial frame. Then in that condition, we have to deduct. And if it is equally clear, that means the power was correct. So in this example, if the patient has preferred position 1, that means he found the image to be clearer when the red markings were aligned with the cylindrical axis of trial frame, then we will add minus 0.5 to the retinoscopic finding which we have. So the final power in this condition would become 0.75. And because we just said that for each 0.5 diopter change, we have to add plus 0.25, just opposite the half power, as we have just mentioned, to maintain the spherical equivalent. So the 0.75 cylinder will become 1.25, but when we add to the spherical component plus 0.25 to keep the circle of least confusion, we have to add to this. So the final power would become minus 0.75 sphere and minus 1.25 dioptric cylinder 120 degrees. The third topic today we'll discuss is the Maddox rod. Now, what is Maddox rod? Maddox rod, when you talk about, it's a handheld instrument which is composed of red parallel plano-convex cylindrical lenses which refract light rays so that a point source of light is seen as a line or a streak of light. Now, due to the optical properties, the streak of light is seen perpendicular to the axis of cylinder. So here, there are the examples of Maddox rod. They can come in different colors, can be green, red, or white. Now, where do we use Maddox rod? Now, Maddox rod test, it can be used to subjectively detect and measure a latent, manifest, horizontal or vertical strabismus for near and distance. The test is based on the principle of diplopic projection. The dissociation of the deviation is brought about by presenting a red line image to one eye and a white line to the other, whereas the prisms are used to superimpose these and will effectively measure the angle of deviation, whether be in horizontal or vertical. And the strength of prism that is increased until the streak of light passes through the center of the prism, as the strength of prism will indicate the amount of deviation which is present. The indications for the usage of Maddox rod are small to moderate vertical deviations where there is simultaneous perception and normal retinal correspondence. It can be used for decompensated phoreas. It can be used in conditions of acquired strabismus. What do we need when we have to test for Maddox rod? Obviously, we'll require Maddox rod. We'll need a light source if it is for near at 33 centimeters. At 6 meters, we're checking for distance. will require prisms, and will require trial frames. So how do we assess if the patient has horizontal deviation? Room lights must be dimmed and only one light source should be visible. When testing at near, the patient is to fixate on a light source at 33 centimeters and at 6 meters for distance. Patient is instructed to fixate on the light source with both eyes open, and then the Maddox rod is placed over the fixating eye. Now, to measure the horizontal deviation, the Maddox rod is placed with the cylinder horizontal, which will make the red line appear vertical. The patient is then asked whether the white light is superimposed on the red line or if it is to the left or the right of the red line. So, looking at the pictures, the inference, what do we get? Suppose a Maddox rod is placed in front of the right eye in condition A. If the patient saw a red line to the right and white light to the left, they are said to have esotropia or phoria or uncrossed diplopia, in which the base out prisms of increased strength would be placed until both get superimposed. In condition B, where the patient sees a red line to the left or white light to the right, they are said to have exotropia or phoria or the cross diplopia, in which the base and prism of increasing strength would be used until the two lines they get superimposed. When we measure the vertical deviation, the Maddox rod will be placed in front of patient's right eye with the cylinders vertical, which will make the red line appear horizontal. Then the patient would be asked whether the white light is superimposed on the red line or if it appears above or below the red line. So looking at the inference, if the line appears below the light, there will be a hyperdeviation in which base down prisms are used to measure and correct the deviation. If the line appears above the light, there will be a hyperdeviation and base of prisms will be used to measure the correct the deviation. And if the white light is superimposed on the red line, obviously there are no vertical deviations present. In conditions of double Maddox rod test, now this double Maddox rod test can also be used to assess torsion and can measure cyclotropias. So how do we carry out this double Maddox rod test? Again, the room lights would be dimmed and only one light source should be visible. The Maddox rod would be placed into the trial frames, one before each eye. The cylindrical lenses will be placed into trial frame vertically, which will make the two red lines seen horizontal. The amount of cyclodeviation is measured in degrees, utilized from the scale on the trial frame. When we test at near, the patient will be asked to fixate on light source at 33 centimeters. And if you test at distance, the patient will be fixating on a light source at 6 meters. Patient is instructed to fixate on light source with both eyes opened. And then the patient will be asked to rotate, or the examiner can rotate the cylinders with the axis knob on the trial frame until the two red lines are parallel to each other. This test can be repeated for secondary and tertiary positions of gaze too. So what are the advantages of using Maddox rod? First, it can be easily performed. It's quite simple and fast technique. It can be used on children if they can respond reliably, and it can be used to even test the eye muscle balance. Disadvantages being that it cannot be done when there are sensory anomalies present. It cannot be performed if a patient has suppression or if they are unable to see the light. It cannot be performed if there is abnormal retinal correspondence, as the angle of separation of the images will not correspond to the angle of deviation. It cannot differentiate between tropia and phorias, and is not suitable for measurement of large deviations, and it is a subjective test. So that's all for today. Thank you so much for your patient hearing.
Yeah, thank you, Dr. Lakshmi. It was exhaustive and a very, very well presented presentation, I must say, and I must congratulate you for the same. And
Thank you, Dr.
I, yeah, I would just like to ask you something. That is there any test with which we can determine whether sometimes patients are wearing a spherical standard spherical power, and when we are testing, they are getting some cylinder, especially when we have a high myopia or moderate to high myopia, and especially when we are taking up them for LASIK. So in those cases, how should we assess that whether we should go, because sometimes the patients are equally happy with both the systems. So in these cases, how should we assess that cylindrical power we should be adding to the prescription, or correcting the cylindrical power with spherical power, or should we be going with the same power which patient is wearing?
I think that's where the JCC is playing its role because
Yeah.
if despite it happens so many times, even if you're getting by through auto wrap, we're getting the cylinder is there, but patient is not accepting. But I think JCC is the one which gives you a clearer picture. And when we just use the flipping technique, and the patient sees that on the one side he sees maybe if there's a minus or the plus, if he says he's seeing the image better, so that is bringing, as we said, the circle of least confusion nearer to the retina. It's making image much better. So I think that's really one of the thing which makes things much easier for us to make out whether the patient would accept the cylinder later on or not.
Okay, and what about duochrome test or any other test we should be, doing alongside it? That
Duochrome test, I do in patients, but I don't actually find it reliable in all the conditions because so many times I've seen patient, they get confused if it's a very small cylindrical bar. Maybe if it's a significant one, then definitely patient would say, I think that reliability is much better if the power is a little more. But if that is so the condition, I think it won't create confusion to us. If it's confusion comes when there's a very small cylindrical power, maybe around zero point 0.5, maybe less than that. So I have seen that patient, they are not able to appreciate much on duochrome test. So I usually won't rely on duochrome if it's a very small cylindrical error.
Yeah, thank you so much. That's all from my side. If any moderator or anybody else,
Yeah,
yeah,
it was really a wonderful presentation, and
Thank you
congratulations.
so much, ma'am.
I think it was quite
Thank you.
exhaustive. But I also want to know, Deepa, I also wanted to know, Lakshmi, in the practical application of this. So, do you think that all refractions would need you to be checked with a Jackson's cross cylinder, or you can do without it? Since we have now so many equipments to guide us about what can be the
Uh,
correct outcome. Or would you
uh,
like to do it for all patients so that you are not making any mistakes?
Ma'am, talking in terms of practical sense, obviously it won't be possible to carry out JCC. It's a very exhaustive and subjective in OPD to carry with all the patients. But yes, I always say when we are teaching, then the student should know. So probably they can practice on the selected number of patients. But if we talk about the clinical practice, where, as we just mentioned, that when we have a confusion and the patient still says, no, he's not that happy. There's something missing in the refractive power, despite because the small cylindrical sometimes it creates problem with the patient. So when we are in a little confusion that whether patient requires that small cylinder or not, then probably we can go with JC, but not for every patient in OPD, I think is required because we have auto RAF and we have no nowadays so much of machines with us that I think probably there's so much of exhaustive test is not required.
and I
And
also,
ma'am,
Also,
what I found also is that
sorry, Deepa, please go ahead.
oh, ma'am, sorry. I just wanted to
uh,
add that in cases of, little bit corneal opacities and patients who have like post-graft corneas where the tests are not very clear, the auto-ref is not showing the axis consistently. In those cases, maybe this has a role to play in, correcting
yes, ma'am.
finding the exact power.
Yeah, I was actually going to ask that when there are corneas which are abnormal, like keratoconus, would that work with this particular concept? Because when you don't have a symmetrical astigmatism, then would it be useful to use a Jackson's cross cylinder like device?
Stenopic slit
Mm,
does help in such cases, but I'm not
It
it
would
sure.
works
not,
for
right?
regular astigmatism. The JCC would be
Yeah.
useful more in case regular
So you
astigmatism. And just
cannot use it for abnormal corneas, right?
yes,
So
ma'am.
where the
And plus,
curvature
ma'am,
especially is going to be abnormal.
exactly,
Stenopic
ma'am.
slit
And I was
can
like
be
about to add this
useful.
point also that because whenever there is a confusion regarding the small cylinders, we should always see the ocular surface because the dry eye, that's such a common thing. I think we miss it in patients. So first you have to see that probably that may be inducing. Like as you've said, the small corneal opacities, the old one, the nebular macular types of a dry.
Right.
So first you have to rule out that we're not missing onto that part. So that probably may be inducing that small, confusing cylindrical power, which might not be basically required by the patients.
And Dr. Lakshmi, how many ophthalmologists, what percentage in your experience know how to do retinoscopy?
Ma'am, ophthalmologist, so ma'am,
That's
I
a
think
tough
hardly,
question.
ma'am, even if I'm talking about optums, they don't know.
Exactly.
मतलब
Optoms definitely don't know
मतलब
because
we can still hire an ophthalmologist. Maybe during our PGs we used to do that. It was such a stressful to do retinoscopy at that time. That was such a major thing. Even the optums, they don't know how to do it. So really, I think we have become so much dependent on autoref now. So I think
it's
really,
actually
not that
becoming a
we are
lost
not
art,
master.
but I think it's a very useful tool. And you've
Absolutely, ma'am.
really nicely shown how it works. And I think that it should be made compulsory for optometrists and ophthalm both to know these
Absolutely,
at
ma'am.
least so that they can use it whenever required. They may
Yes.
not use
Ma'am,
it
it comes very
routinely,
handy.
as you said.
Absolutely,
And
ma'am. It
these
comes very
days,
handy when we see a small child. We can't do autoref in a small child. So when I do ROP,
Exactly.
that's biopic shift, it becomes very handy to at least know the error in those patients.
and also, ma'am, not in small kids as well as young adults, they are very, very specific. They will not accept even a 0.25 here and there. And I've seen patients reading 6 by 6, still they'll say, I'm not seeing properly. And then you have to give them 0.25. Even they are ready to wear that and their vision becomes better. So for that 0.25, 0.5 we are giving, we have to be very sure of the, power that it should be exact.
Absolutely.
Yeah.
But having said that, I think we've had a good session because it was very useful. In fact, I also learned a couple of things. Thank you, Lakshmi. And
Thank you so much, ma'am.
if there's nothing else, o-
We have
over
a
to
Yeah,
question,
the
ma'am.
yeah. So
We have a question from one of our DNB students. They're asking whether how should we approach patients with the irregular astigmatism? Should we go for spectacles, contact lenses, or should we explore surgical options?
Lakshmi, would you like to take that question?
Ma'am, I'll try for this. For the irregular astigmatism, definitely the glasses won't work. We have contact lenses, which again would be a rigid contact lenses. And as far as the corneal transplant keratoplasty is required, or maybe in the refractive surgeries, that definitely would be go if the patient is not responding well to the rigid contact lenses.
Yeah, but if they show an improvement after wearing rigid contact lens, then they could go for a topographically linked corneal reshaping, which can then remove some part of the irregularity, and that can improve the vision. So just yesterday, I had a discussion with a doctor. He was saying that his patient is just reading less than 660 with whatever correction he's trying to place. But with a contact lens on, a rigid contact lens with no power, he can reach up to 612 minus 2. So in such cases, it would definitely help to regularize the cornea by doing a topo-linked PRK or a topo-linked corneal reshaping so that you can have an improvement in the corneal curvature and therefore vision.
But
Ma'am,
ma'am,
I
to
have
assess,
one question from you. If we talk about the rigid contact lenses, how long we can suggest patient to go with it? Because giving no contact lens for such a long period, will it's going to cause some issues with the patient, or weaken such conditions? If the patient is improving significantly, as you mentioned in one of the case, we can ask the patient to go for the corneal resurfacing, as you've mentioned.
Better to do a corneal resurfacing. This particular patient was very old. He was also pseudophakic, but and one-eyed. So this was the only chance for him. That's why we have planned to do this coupling PRK.
and sometimes,
I think
ma'am,
probably the giving the rigid, yeah,
just
sure,
like
sure,
to
please,
add
Dr.
that in cases which where laser is not possible or feasible, in such cases, these days, most of the patients they don't prefer RGPs because the size is small.
Yes,
It is very cumbersome to put and it falls down, and then sometimes it can cause apical scarring. So these days, this scleral lens and the mini scleral lens
yes.
also they work beautifully. And especially
Yes.
in patients who have ocular surface disorder, so it has a add-on surface protecting effect as well. So they work
True.
one, especially in eyes you don't want to touch. And if it's a advanced keratoconus, it's not possible, and patient is not willing for the surgery as well. So in such cases, we can go for
Sure.
these lenses. Yeah.
And otherwise, of course, we have the option of going for one of the keratoplasties.
Yes, ma'am.
Ma'am, there's another question which says, how should we handle cases where the subjective cylinder axis differs significantly from the corneal topographic findings?
I think in these cases we have to go with the subjective cylinder rather than the topographic. I mean, that's what I have seen, that sometimes it can be different because of the lenticular astigmatism as well. So, I mean, ma'am would add.
No, no, definitely. And this must be coming from a refractive surgeon, because they are the ones who are really bothered about this difference between the axis of the cornea, so coming from the topography and the acceptance. And it's not uncommon to find a difference between the two, though in most cases it would be matching. But if it is, then as Dr. Deepa already pointed out, it is coming from the lens. And if the lens is not having any sclerosis or cataract or anything, and if you're planning a refractive correction, it's better to take the manifest refraction and treat that rather than what is coming from your cornea.
And also, we must dilate the patient to see if
Yes,
there is any zonular dialysis or something. Such
yes,
patients tend to
very
have
important.
drastic, drastic change of the axis and
Sure.
spherical power. So that must be checked as well.
Especially if there is a difference between the two eyes, you have to be very careful. Also, make sure that it is not changing over a period of time before you actually take these patients up for refractive surgery.
Okay, ma'am. Thank you, ma'am. As of now, we don't have many more questions. We can
So,
end the session, ma'am.
sure. Thank you, Survin, and thank you, Dr. Lakshmi, for such a wonderful session and making us a part of that.
Yeah.
Thank you so much, ma'am.
Thank you,
Thank you.
Sureen, and thank you, Dr. Lakshmi, for an excellent presentation and making me a part of it. Thank you.
Thank you,
Goodbye.
Dr. Diva. Thank you so much.
Thank you, ma'am.
Bye.
Thank you, Roswin.